So good afternoon, everyone. I'm Nida Zahid, as Dr. Vikram has introduced me. I'll just give a quick background regarding my I'll give a quick educational background of myself and my professional affiliations. So I've done my bachelor's in medicine and bachelor's in surgery from Bida Medical College, Pakistan. After that, I did my master's in epidemiology and biostatistics from the University, Pakistan. Last year, I did my PhD in medical sciences from the Uppsala University, Sweden. I'm a fellow of Royal Society for Public Health, and currently I'm a postdoc fellow at the Harvard Medical School. So my first year will be over here, and then next year I'll go back and implement my project over there. So I'm assistant professor and former vice chair research at the Department of Surgery at the Aachen University. I'm an affiliated researcher at the Uppsala University, Sweden as well. So this is my small little family, my two boys, 17 and 10-year-old, and my husband. So today I'll be presenting my PhD project that I defended last year. So I'll be talking about the risk factors and late effects of primary brain tumors in children and young people treated in tertiary care hospitals of Karachi, Pakistan. So this is my supervisory committee. My main supervisor, Dr. Nick Brown, who is an epidemiologist and a pediatrician at the Uppsala University, Sweden. Dr. Syed Athar Inam, who is a neurosurgeon and a neuroscientist at the Aachen University, Pakistan. Dr. Anders Martinsson, who is again a physician and a researcher at the Uppsala University, Sweden. Dr. Thomas Martinsson, who is a pediatrician and a researcher at the Uppsala University as well as the Karolinska Institute at Sweden. And this was the advisory committee from the Aachen University. So Dr. Noreen Mushtaq, who is a pediatric neuro-oncologist, Iqbal Azam, who is a statistician, Maria Muchala, who is a psychologist, Mohammed Noman Mughal, who is a basic scientist, Sadaf Altaf, who is a pediatric oncologist, and finally Salman Kirmani, who is a geneticist. So the flow of the presentation will be, I'll start with the background, followed by material and methods, results, methodological considerations, discussion and conclusion, and finally future directions. So let's start with the background. Globally, primary brain tumor are the most common solid neoplasm and the leading cause of malignancy-related death in children and young people. Approximately 250,000 new cases of central nervous system malignancies are diagnosed annually, accounting for 20% of all childhood malignancies. The osteoporosis, it accounts for almost 50 to 60% of brain tumors in children and young people. And histologically, medulloblastoma and pilocytic astrocytoma are the two most commonly occurring brain tumor types in children and young people. So in children and young people 0 to 24 years, the crude incidence rate of brain and CNS tumors is 1.2 per 100,000 globally, 2.6 per 100,000 in high-income countries, 0.92 per 100,000 in low and middle-income countries, and finally 0.89 per 100,000 in Pakistan. So when we talk about the risk factors of brain tumor as reported in literature, it includes socio-demographic factors such as younger age group, male gender, high socioeconomic status, family history of brain tumor, and family history of other cancers. There are some antenatal and natal risk factors as well that play a role, which includes higher parental age at birth of the child, parental exposure to pesticides, smoking, and additives, maternal exposure to medicines such as antihypertensive, pain relievers, diuretics, hairspray and color, vaginal infection, exposure to ultrasound and x-rays, and consumption of cured meat, and higher birth weight of the child. So improvement in detection and intervention has decreased the mortality rate in the primary brain tumor survivors by almost 14% from 2010 to 2020. However, adverse side effects encompasses the cumulative negative consequences of the unfavorable outcome that develop over time following the initial treatment. Between 65% to 75% of childhood brain tumor survivors develop at least one recognized late effects, which can manifest as medical, neurocognitive, and psychosocial. So the main outcome of this of our study were the neurocognitive and the psychosocial outcomes in the children and young people with primary brain tumor. So when we talk about late neurocognitive effects, it can be defined as difficulties with thinking, learning, and memorizing. They manifest 1 to 5 years post-treatment, and at least 40% of the patients, they show impairment in at least one neurocognitive domain. There is evidence on neurocognitive and psychological outcome in primary brain tumor survivors from high-income countries. However, only one cohort study from India has assessed the neurocognitive decline in children with medulloblastoma. So the DSM-5, it defines like six major domains of neurocognition, which further are divided into subdomains, which include the executive functioning, the perceptual motor function, language, learning and memory, social cognition, and complex attention. So evidence suggests that children and young people with primary brain tumors are at greater risk for depression, anxiety, suicidal ideation, and behavior problems relative to general population. Sense of well-being, family functioning, parent-child health-related communication, and social involvement have all been implicated as areas of risk after primary brain tumors. Only 3 cross-sectional studies from low and middle-income countries have been reported. This is just a snapshot of the studies in regards to the research regarding neurocognition and quality of life outcome in children and young people with brain tumors. A cross-sectional study from Indonesia, it assessed the quality of life in children with brain tumors treated with radiotherapy, and they found that higher family income was associated with higher quality of life scores. A cross-sectional study from Jordan, it assessed the quality of life of pediatric brain tumor survivors, and it found that tumor location, male gender, and hypopituitarism were associated with low quality of life. A cohort study from India, which assessed the neurocognitive decline in children with medulloblastoma treated with radiation therapy alone, found that there was a neurocognitive decline of less than 1 IQ point per year over a 10 years period. And a cross-sectional study from Pakistan, it assessed the quality of life of children with craniopharyngioma, found a significant effect of type of surgical treatment on the quality of life. So this was the conceptual framework of the study. So to assess the risk factors of primary brain tumor, which includes the socio-demographic factors, family history and genetic factors, and antenatal and natal factors. The adverse effects, which are commonly, there, and what was assessed in my study was the neurocognitive decline and the quality of decline in the children and young people with primary brain tumor. So there are several factors that lead to this decline, which includes the tumor and treatment-related factors, which can be tumor type, size, extent of surgery, chemoradiotherapy, seizures, length of treatment. Then there are child-related factors, which can be age at diagnosis and treatment, pre-tumor functioning, cognitive reserve, pre-existing condition, and genetic vulnerabilities. And environmental support, which includes school community support and accessibility. And finally, parental factors, which can be the educational status of the parents, marital status, the socioeconomic status, age. And ultimately, these neurocognitive outcomes and quality of life outcome in children can have an impact on the quality of life and the family functioning of the primary caregivers as well. So the rationale behind the study was that most studies from high-income countries on late adverse effects in children and young people with primary brain tumors are cross-sectional, and majority of the longitudinal studies lack clearly defined baseline for later comparisons. Differences in healthcare access and socioeconomic status makes it inappropriate to extrapolate data from high-income countries to low and middle-income countries. So data from this PhD project has enabled in assessing the direction and magnitude of these adverse effects, and it may also serve as a platform for integration of formal neuropsychological assessment at critical points in patient care. So the overall aim was to assess the risk factors of primary brain tumor in this particular population and to evaluate its late effects at tertiary care hospitals of Karachi, Pakistan. And the specific objectives so it had 5 major objectives. The study 1 was to determine the socioeconomic, sociodemographic, and antenatal risk factors of primary brain tumors. Then the second objective was to determine the mean change in neurocognitive scores 12 months post-treatment and the factors associated with it. And the study 3 was to determine the mean change in quality of life scores 12 months post-treatment and the factors associated with it. The study 4 was to assess the mean change in quality of life and family functioning scores 12 months post-treatment among the primary caregivers of the children. And finally, the study 5 was to explore the microRNA expression and its correlation with 12 months post-treatment neurocognition outcome. So now I'll come to the material and methods. This is a brief description of Pakistan. Pakistan has a population of over 220 million. The major cities include Islamabad, Karachi, and Lahore. The health expenditure is about 3.2% of the GDP. 23.4% of Pakistanis live below the poverty line. and about 56% of the population pay out of pocket for the medical treatment. The mortality rate for individuals aged 5 to 24 years range from 3.4 to 5.8 per thousand population. So my study was majorly, conducted at two study sites. The study site one was the Arkan University Hospital, which was established in 1985. It's a private tertiary care 560 bedded hospital in Karachi, Pakistan. While the study site two was the Postgraduate Medical Center, which was established in 1963. It's a public tertiary care 1600 bedded hospital located in Karachi, Pakistan. So in talking about the study one, which was to assess the risk factors of primary brain tumors, the study design was a matched case control study. And the cases were children and young people with primary brain tumor aged 5 to 21 years, while the controls were those children presenting to the hospital with non-oncological diagnosis, and they were matched on age and gender. The sample size was calculated by PAS11 software, and our sample size was 122 pairs. The study site for this particular objective was only the Arkan University Hospital, and the data was collected on a pre-designed questionnaire which included child-related factors, parental factors, and antenatal factors. The data was analyzed by Stata version 12, and we applied the conditional logistic regression. So for the study 2 to 4, which was to determine the quality of life and the neurocognitive outcomes in children and the quality of life of the primary caregivers, was a prospective cohort study, and the study participants were children aged 5 to 21 years with primary brain tumors and their primary caregivers. The study site was both the hospitals, that is Arkan University and Jinnah Postgraduate Medical Center. The outcome that we assessed was mean change in neurocognition and quality of life scores at 12 months post-treatment. And the data was analyzed by Stata version 12, and we applied the pair t-test and generalized estimating equation regression analysis. So the tools that were used for the assessment of neurocognition was, so there were three things that we assessed. It was verbal intelligence, which included the verbal intelligence, and secondly, the non-verbal intelligence, which was perceptual reasoning and processing speed. So for verbal intelligence, we assessed it via Slauson Intelligence 2 Revised Third Edition, that's commonly known as SITS-R3. The reason for choosing this was because it is alternative, longer, more time-consuming intelligence test. And it is usually, we can assess it on children from age of 4 to elderly of 65 years. And it generally assesses the 6 cognitive domains, which includes general information, comprehension, quantitative, similarity and differences, vocabulary, and auditory memory. It uses a contemporary language, and it's free of any significant demographic, racial, or gender bias. It's widely used in schools, clinics, and industry, and it is cost-effective. So for the Urdu version of the tool, we conducted a content validation, which was done by sending the tool, the translated tool, to a panel of 5 experts, and who rated the items on relevance and clarity on like a scale of 1:4. And so the CVI, that is Content Validation Index, came out to be 0.9, while for relevance, and for clarity, it was 0.89, which is considered to be a good validation. So this was the second tool that was used for assessing the perceptual reasoning. This is the Revens matrices, and this again is validated in Pakistan. And for processing speed, we use a Wessler intelligence scale, and this was also validated in Pakistan. The quality of life that we were used was the PEDS quality of life inventory for generic tool and a brain tumor module. So when you talk about the generic tool, it yields a total global score and 4 subscales, a score which is physical, emotional, social, and school functioning. And a high score represents a better quality of life. It comprises of a child's self-report and a proxy parent form as well for different age groups from 2 to 25 years. The brain tumor module, it comprises of 6 different scales, which include the cognitive problems, pain and hurt, movement and balance, procedural anxiety, nausea, and worry. Again, the high score, it represents a better quality of life. So this tool, again, was not validated in Urdu language, so we translated and validated it. The Content Validation Index for relevance and clarity demonstrated excellent agreement for both child, young, adult self-reports. That is, it ranged from 0.82 to 0.93, and for parent proxy report as well, which ranged from 0.89 to 0.92. So the study 5, the methodology for study 5, which was an pilot exploratory study in which we wanted to explore the microRNA expression and its correlation with 12 months post-treatment neurocognition. We collected 2 5cc serum samples from the children pre-treatment, 48 hours post-surgery, and 12 months post-treatment. And the microRNA expression was assessed by QRT-PCR, that is polymerase chain reaction. The data was analyzed by the R software and was assessed by paired t-test and correlation analysis conducted. So ethical approvals were obtained from both the study sites. For study 1, because it was because the mothers were interviewed via telephone, so verbal consent was obtained from the mothers, and while for study 2 to 5, written consent in a sense were obtained. Confidentiality and privacy of the study participants was maintained. Data was stored in a password-protected database at the Khan University Hospital, accessible to the research team only. The parents were not charged for neurocognition molecular assessment, and the participants with neurocognitive and quality of life decline received treatment guidance from a psychologist. So now I'll come to the results. So this is a flow of the study for study 1. So medical record numbers of children 5 to 21-year-old with and without brain tumor were extracted from the Health Information Management Service at the Khan University Hospital. 122 cases were selected and 122 controls were selected matched on age and gender. Telephonic calls were made to the mothers of both the cases and controls. Verbal consent was obtained and information was taken from them regarding the socio-demographic and antenatal factors. So this is the conditional logistic regression model, which shows that paternal education had a significant association with the child having with brain tumor. And we could see that those fathers who had no or primary education, their children had a higher odds of having a primary brain tumor. Similarly, when we talk about household monthly income, those with high household monthly income had higher odds. Their children had higher odds of having primary brain tumor. While those mothers who used painkillers during pregnancy, their children had higher odds of having brain tumor. Similarly, paternal use of addictive, which was usually it was smoking during the pregnancy, their children had higher odds of having primary brain tumor. So this paper is published in the Journal of Public Health Research. If you want to have a look at it, you can always have a look at it. So this is the study flow of the study for studies 2 to 4, and we screened about 60 newly diagnosed children and young people aged 5 to 21 years with primary brain tumors from the neurosurgery and oncology clinics at the 2 study sites. We excluded about 12 patients, and there were various reasons. It was either language barrier, educational. There was no education because one of the inclusion criteria was that they had to have some basic education, or they were too ill to give the, you couldn't do their assessment because of their ill health. So we enrolled 48 children, young people, and the primary caregivers. Pre-treatment assessment of, so these patients, they were all treatment naive. They were just, newly diagnosed cases. So pre-treatment assessment was done of these children and the primary caregivers by a trained psychologist. And at a 12 months follow-up, unfortunately, about 23 of our patients, they were lost to follow-up. And there were various reasons. 10 of them, they died within this 1 year time period. Few of them, they were not in the condition. They were, their health deteriorated to the extent that we couldn't assess them. And a few of them, they were not reachable. So at 12 months post-treatment, we were able to assess about 25 children, young people, and their primary caregivers. But the good thing was that when we calculated the sample size, we inflated it by 30%. So, we were still able to, the study was still powered enough. So this is just a quick, glimpse of the description of our participants. So we can see that the mean age of the patients was about 12.8 years. A higher proportion were males. The province of residence was Sindh because, Karachi is located in the province of Sindh. So these are some tumor and treatment related factors. A high proportion presented from the private tertiary care hospital. We can say that we recruited more patients from the private tertiary care hospital due to the completion of the, the records and the a better follow-up of the study of the participants. The location of the primary tumor was infratentorial, majority of the cases. A high proportion had grade 1 tumor. And when you talk about the histopathology, a high proportion had pilocytic astrocytomas. About 21% did not undergo any surgical intervention. However, those who did, a high proportion had maximum safe resection. So we did do a risk of bias assessment to see how our participants who were followed versus those who were lost to follow versus those who died, how different or similar they were. So in majority of the, in socio-demographic and treatment and tumor-related factors, they were very similar. The only difference that we found was in gender, and we could see a higher loss to follow-up among females as compared to males. So this is the regression model, which I presented in form of a forest plot. So as I mentioned earlier, we assessed the three major neurocognitive outcomes, that is verbal intelligence, perceptual reasoning, and processing speed. And we can see that those children who had post-treatment seizures, they had a significant decline, 12-month significant decline in the verbal intelligence score as well as in the perceptual score. When you look at the educational status of the mother, those who had no or low formal education, their children they tend to have a significant decline in the neurocognition. And those who belong to lower household monthly income, they had a significant decline in the neurocognition. So this was the forest plot for mean change in processing speed scores, and the very similar, variables were found to be significant with the decline that is post-treatment seizure, household monthly income, and educational status. However, we can see that when we talk about the histopathology, those who had high-grade tumor, like glioblastoma and ependymoma, they had a significant decline in their neurocognition as compared to those who had pilocytic astrocytoma, which is a low-grade tumor. However, craniopharyngioma, which is a low-grade tumor, the children they did have a significant decline in their neurocognition, and that I'll discuss further, that what could be the reason behind it. So this paper is again published in Child Nervous System, and you can always have a look at it. So this was the third study to show the predictors of quality of life outcome in children and young people. And what we found that those children who underwent surgical resection, that is a total resection and maximal safe resection, they had a significant improvement in their quality of life outcome. However, those children who had hydrocephalus or there was placement of shunt or the extraventricular device, they had a significant decline in the 12-month neurocognition outcomes. So this paper is also published in BMJ Pediatrics Open, and you can have a look at it. So this was the fourth study to see the predictors of quality of life and family functioning outcomes in primary caregivers. And in majority of the cases, the primary caregivers were the mothers. And we can see again those children who had post-treatment seizures, their mothers had a significant decline in the quality of life and family functioning. Post-treatment financial burden of the child's disease had a significant impact on the quality of life and family functioning of the mothers. However, those children who had, good quality of life score, that is post-treatment, their mothers had a significant improvement in their quality of life. And similarly, those children who had a higher verbal intelligence scores, their mothers had a significant improvement in their quality of life. So this paper is again published in BMC Pediatrics. So you can again have a look at this. So this was the final study that was to see the correlation of microRNA expression and neurocognition. So this is a heat map which shows a correlation between the microRNAs and the cognition factors. So we assessed around 5 microRNAs, that is microRNA 21, 210, 10B, 296, 5P, and 146A. The reason for choosing these microRNAs because a research group have already conducted the study to see their expression in brain tumor amongst children. And there has been a significant impact of the expression of these markers. So, and unfortunately, no studies, there have been studies that have been done, looking at the correlation between microRNA expression and cognition in adults with manic depressive disorders, with schizophrenia, with Alzheimer's, but there have been no study conducted, especially in children, in regards to in the brain tumor children in regards to the correlation of microRNA expression and cognition. So this is to best of as to my understanding, this is almost the first study that is there in literature. So we could see a significant correlation between the pre-treatment microRNA 210, and there was a negative correlation with post-treatment perceptual reasoning, and a positive significant correlation was seen between the microRNA expression 10B with the post-treatment processing speed score. So this paper is again published in Brain Tumor Research and Treatment, if you want to have a look. So there were some methodological consideration when you talk about study 1, which is a case control study. Recall bias, and it is inherent in case control study that we do anticipate. Selection bias cannot be ruled out. Healthy controls, unfortunately, could not be recruited due to lack of population-based registries. Reporting bias can be anticipated regarding maternal and paternal addictive, especially maternal addictive use. And data on opioid and non-opioid analgesics separately could not be assessed. When we talk about the study 2 to 5, unfortunately, more than 50% of children and their primary caregivers were lost to follow-up. We do anticipate heterogeneity with respect to tumor histopathology, which actually led to small numbers in each. Neurocognition and quality of life were assessed only at 2 points. Could have been done, maybe at a longer period, but because due to the time frame of the PhD project, I was restricted to 12 months. Endocrine profile could not be assessed, and what literature shows that endocrinopathy, it plays a significant role in cognitive outcomes, especially in craniopharyngioma, because that's located very, very much near to the pituitary gland. So I guess this is what we anticipate, that maybe, the decline in the children's outcome, neurocognition outcome in craniopharyngioma, maybe because of the endocrine might be playing a role. Moreover, microRNA analysis was done in serum, which is challenging as it is heterogeneous, originating from various tissues. That does complicate the isolation of tumor-specific microRNAs. Additionally, abundant protein and lipids can impede the effective microRNA extraction and analysis. So maybe a tissue of the tumor tissue would have been a better option as compared to serum. So quickly, I'm going to discuss the studies and the conclusions. So as I mentioned, that maternal analgesic use in pregnancy does have an impact on, is linked to increased odds of primary brain tumor. However, this was a new association because prior only studies have been done on opioids. So on the other hand, smoking again was, found, paternal smoking was found to have a strong association. Possibly it might be via maternal secondhand smoking exposure. And higher household monthly income, we anticipate that it was an unexpected correlation because of the case ascertainment bias, and due to better access to diagnostic care, those who have better, they belong to a better socioeconomic status, they have more access to it. However, low paternal education was independently associated. So the implication of the study were that need for public health intervention, the smoking cessation, secondhand smoking reduction during pregnancy is important, equitable cancer care to reduce ascertainment bias, and further population-based studies are required. So for study 2, when you talk about the neurocognition, we could see the tumor type. It had a significant, especially the histopathology, it had a role. And as I mentioned earlier, the craniopharyngioma is probably due to the endocrine disruption. Surgical resection was actually led to an improvement in the processing speed score. And what we anticipated was likely from the relief of the mass effect and the CSF, that is the cerebrospinal fluid flow restoration. Post-treatment seizure did have a significant decline on the cognition effect, and lower SCS and low maternal education of the mother, it was associated with worse neurocognitive outcome. And we anticipate that was, the resources that are available for children, as well as, affluent schools that have better resources for these children, especially those who need special, treatment or special care, that's available, at more affluent schools as compared to the other schools. So ultimate implication of the study was early psychological and cognitive screening, seizure control and endocrine follow-up are critical. Equitable educational support and resources can mitigate the SCS-related deficits. Timely surgery and multidisciplinary care may preserve or restore neurocognition. So what we have seen that in low and middle income countries, for every one neurosurgeon, there are around 139,000 individuals who are getting treated. While in high income countries, for every one neurosurgeon, it's 80,000 individuals getting treated. So we need more, I think more surgeons are required so that people can get access to neurosurgery care. And in the study 3, which was the quality of life, quality of life had the resection of tumor had a better impact, and that again is mass-related effect. And the study 4, that is the quality of life of the parents, we can see that, the ultimate implication of this study were that it's important to have targeted support and mental health referrals, financial assistance, and cognitive rehabilitation that can reduce the caregiver strain. So study 5, that's a microRNA expression, when you talk about 210, it has a hypoxia response, which modulates in neuronal plasticity and neurodegeneration. And it basically targets these genes that have a role to play in the neuroplasticity. So this may reflect in tumor hypoxia and related cognitive impact. However, when you talk about microRNA 10B, so 210 has an oncogenic role in the brain tumor, and we could see a similar correlation. The direction of the correlation with neurocognition was very similar. That is, as the expression was increased, the neurocognition was decreased or declined. When you talk about the microRNA 10B, it had a positive correlation with neurocognition, especially processing speed. And it basically is involved in neuronal survival and repair. And it helps in regulation of the BDNF gene. So it actually has a dual role in cancer biology, but for brain tumors, it has a positive role, right? It acts as a tumor suppressor, right? And we can see a similar direction of the correlation with the neurocognition. So ultimate implication of this study were that circulating microRNAs are promising microRNAs, biomarkers for neurocognitive risk and recovery after brain tumor therapy. Suggested pathway includes a hypoxia adaptation, synaptic plasticity that could be targets of neuroprotective interventions. But however, we do require longer longitudinal validation study to confirm the clinical utility. So the future directions are findings from the study can lead to the formulation of specific recommendation in prenatal care, ongoing collaboration among neurosurgeons, neuro-oncologists, neurologists, psychologists, neuropsychologists, caregivers, rehabilitation centers, and educational institutions is essential. Emphasizing family-centered care and fostering social support initiatives. However, to establish generalizability, future research should prioritize large-scale multi-country studies. So these are just a few snapshots from my PhD while I was defending my thesis. And this is after deliberation group picture with my examiners and with all my supervisors. So thank you.
Okay, thank you, Nida. Questions and comments. I just wanted to ask you, maybe Nida, just kick things off. Just thinking about the postdoc and what might be the ideas that either build on or extend your doctoral work. Oftentimes a postdoc is a time to write up, but also it's a time to sort of think about the transition from your being a graduate student to essentially becoming an established faculty member. So just want to hear your thoughts about what you're thinking about.
So there are one or two ideas. One idea is that working on dementia patients, older age group, to say that because with time, as time is passing by, even the aging population in LMICs are also increasing, right? So now the cutoff for the life expectancy even in the low middle income countries has gone up to 70 years. So we do, this is one idea that we do have, that looking at the factors, that are causing, a significant decline in the cognition among patients who are, diagnosed with dementia. So that is one thing that is there. And we might look into comparing this group of patients with patients who have cancer, and compare that how same age group patients with dementia, with and without cancer, having dementia have, what is happening to their cognition outcome. So so that is one thing that we might be looking at, because at the moment I have studied literally all the age groups starting from children to adults, and now I want to maybe go to the elderlies and see that how is it different in patients who have cancer versus those who do not, and patients who have dementia, how is their neurocognition outcome, how are they being impacted. So but still it's work in progress. I need to discuss it more with my supervisors, and then hopefully next year I'll be presenting a short proposal.
Thanks, Nida. The other Anushka, sorry.
Yeah. Thank you so much, Nida. Really, really interesting work, and clearly highly productive. It's amazing.
Thank you.
I kind of have two questions for you. So I'm very interested in the fact that you measured executive functioning, because that's obviously a very big predictor for future student achievement, success, et cetera, et cetera. And I'm kind of curious if any of your predictors did have significant associations to executive functioning. And the second thing is, the research on mRNAs was very, very interesting. It's new to me. I'm not a kind of biologist or a real doctor, quote unquote. And so one of my questions for you is, how experimental is mRNA work? Like, or are there already mRNA therapeutics that are being developed to treat pediatric cancer?
Not at the moment. I mean, of course, when I talk about LMICs, no, they are still in the process of, they're still finding out what are the microRNAs that are really there, is their expression, related to this, the primary brain tumors. And we're still in process of that. And, but yeah, internationally and globally in other parts of the world, they have started working on it. So, as I mentioned, so especially in this group of patients, I mean, assessing the neurocognitive, because we do need some objective measures. The rest are very subjective, but this is one objective measure. So this is almost, in literature, it is the first kind of the study, which explored in this group of patients. So, but it was it was an exploratory study. So we would want to do a larger scale study and maybe focus on specific tumors, because right now we included all tumors, right? So maybe, and that's how we had a very heterogeneous group, a very small numbers in each tumor type. But, having, maybe a homogeneous group would be more fruitful. Second question was?
It was about our executive function and if you found any of your predictors having significant associations with EF, because
so as I mentioned earlier, that type of surgery had a very significant effect on your executive functioning. Especially when I talk about, so there are three types of surgeries that are there. It's total resection, that means that 100% of the tumor is removed. Then there's maximum safe resection, which means about more than 90% of the tumor is safely removed. And then there's subtotal resection, which is less than 90. So what we found that those who had total resection, as compared to those who did not have any surgical intervention, even in surgical intervention, total resection had a better outcome on the neurocognition. So I feel that, because of the mass effect, that actually influences the neurocognition and the executive function. So I think the surgery itself is a very important, area. However, unfortunately, what we have noticed that due to financial constraints, especially presenting to a private tertiary care hospital, where of course the care is better, people, they end up not getting their surgeries done. So I think, maybe more opportunities and more access of care needs to be provided to people so that people can, get their kids, surgery done.
Thank you.
Yeah.
We have a couple of questions.
Yeah.
Thank you so much for the presentation. One is, you mentioned that around 50% of the participants have been lost to follow-up. Do you know what percentage of the female participants were lost to follow-up?
Yeah, so as I mentioned over here, about 60%. So we did the risk of bias assessment, and we can see over here that about 61% of the females were lost to follow-up. Okay. So, what we anticipate, it's a patriarchal society where males are given more preference over females. And so what we anticipate that maybe, when a female child starts deteriorating, so especially not maybe because people were presenting not only from the urban settings, they were also presenting from rural settings as well. So what we anticipate that maybe, they are more, I think they are more they're more concerned about a male child as compared to a female child. That's just an anticipation as per the, the patriarchal society that we have. So yeah, 61% were lost.
My other question is, do you know if there are these children and young people receiving any treatment? Like you mentioned, they received guidance on treatment, but are they receiving some cognitive remediation, or what exists actually, and how available is it?
So the good thing is that we had on board a psychologist, and she is an expert in neurocognitive therapies and assessment. So, initially the patients were sent, she just guided them, but ultimately, for those patients who were not affording, she gave them, proper therapy free of cost. While those who were affording on a lower subsidized rate, she gave them therapy. I mean, a whole, thing. But generally, when we talk about brain tumor children, focus has always been on treatment and the disease itself, not on their mental health outcomes. So this is what our recommendation, and which I recommended to the neurosurgeons as well through our study, that this should be a part of management, because a lot of patients, they did mention that, because of the financial constraints and due to time as well and their priority, for them treatment is more important, but then they do realize that, your mental health outcome, that they're very important.
And it can get in the way of getting good treatment.
Yeah.
If you're severely depressed or
Exactly.
something. So
Exactly.
yeah.
And it was mostly like therapy for like the psychosocial therapy, or was it,
It was
also cognitive?
neurocognitive.
Okay, I just closing remarks. Nida, your work is really important in the sense that it captures an area of global mental health, which I think is very understudied, which is neurocognitive impairment, which is not typically a mental health condition. It's really I'd say it's like a deep phenotype of mental health problems. And what we often do is just study the symptoms. We never really study what's happening, in the brain. And this is the most accessible, I'd say, biomarker almost of many mental health conditions. And some of the questions that Anushka was asking was, related to that. And as you think of your postdoc, and of course we'll talk more about this, maybe one of the things to ask yourself is, what do you want to be doing in your career going forward? And there are at least two quite distinct, and oftentimes they're not that overlapping roles. One of them is being much more hospital-based, in which your primary goal is to work as part of, this is a bit like a liaison consultation kind of model. You're working with very, very complex medical conditions and asking questions to do with neurocog impairment. And in that context, the key question, it seems to me, is really what kind of interventions, and I think Mercedes was speaking to that point, can actually improve the overall health outcomes of that individual, whether it's a child or adult or an older person. That's your choice, but the fact is, that's the question. What can we contribute from the mental health field that can help in the team-based management of that individual? That's typically what consultation liaison work is about. And then there's another way of looking at your skills and interests, which is, what is the relevance of neurocognition in population mental health? And because you work with kids, there's an obvious, the whole field of early child development is really around this. It's the substance of early child development. The word development is really essentially neurocognitive development. And that's a very understudied field. It's a very important field. And you may want to also look at that. So this is not asking the question, what's the relationship with brain cancer? But you're really just simply asking what predicts neurocognitive impairment. And I'd say some of your risk factors may in fact have nothing to do with the tumor in the brain. You may have, like your parental, like the low education of the father or something like, there was a low education. That's actually a universal finding. It has not. It's found whether or not you have a brain tumor. You're going to find that. And so, at a population level, that's a very important, area of work. And many people in this lab work on early child development, including Laura here. And the other spaces, when you mentioned dementia, I thought you would be referring more to the application of these assessment methods towards assessing people with neurodegeneration in older age. From again a global mental health perspective, totally ignored. I mean, totally no, but to a large extent understudied, and I think a hugely important issue in Pakistan as it ages. And so, the key thing is, where do you want to be? Say 5 years from now, do you see yourself as being part of a consultation liaison team? Because that will take you in a certain direction for your postdoc. Or do you see yourself as part of a global mental health team, which tends to work outside the highly specialized settings? And you'll have seen many examples of the work of the lab as illustrating that. It's a continuum of care, but your specialties and skills will differ according to where in those levels of care you're going to be primarily working in. So to be continued. And but it's certainly an important part of your own self-reflection. Where do you want to be in 5 years? John, please.
I think it's very, very interesting work, and I think the neurocognitive assessments are just totally not scalable. It's an impossible thing to scale. So we have a program using mobile. We're trying to design and validate mobile devices for neurocog assessment in people with schizophrenia. And this is ongoing in India, and just the sharp round two.
The mind map?
We're using mind map.
I didn't know there was a neurocog.
That's our new welcome program. Yeah. So and it's been actually working very well. We've been validating these different assessments using the mind map application.
Actually, that's a good point.
And I'll share a couple. We have a paper that just came out like last week.
Oh, please do, yeah. Also said occasionally, so it goes on our newsletter. But actually, I'm glad you reminded me that is an issue. And again, this also reflects the difference between specialized settings and community settings.
Yeah.
It's completely reasonable, and I think quite likely that when you're working in such a tertiary hospital like Arkan, we're doing these long neurocognitive assessments. It's very, very part of the course. It's like doing an MRI brain scan. You would never think twice about it because it's what you do in these hospitals. But if you go out in the population, it's not going to work. It's just no one does, not even here with all the resources. Nobody would be doing these assessments in populations. And digital tools, like I did not know about that tool, but another one I can share with you is my colleagues in Sangat have developed a digital tool that now has been validated in Malawi and India and in population settings. I can share, there's a whole slew of publications that have come out describing that tool. That's if you were working in a population setting with children, then I think the future is in digital assessments that are combining parent report with direct assessment of a child. But of course, that's only children 2 and above, because younger kids will not be able to interact with the gamified environment.
And the mobile devices offer the option to capture multiple time points. Because the one other issue is that with the standard neurocog assessment, you're in a room, doors closed, you get these questions, but you only have that one window, whereas that doesn't get a full picture. A lot of things, and then things, especially when cognition can change throughout the day, conditions, whatever's happening around. So I think there's other, trying to think of other ways to capture a more complete picture, but also something that's cheap and scalable.
Well, passive sensing data, right? When you're doing it from the phones too. So looking at activity levels, this kind of thing.
Yeah, it's a combination of passive and active.
So, Dr. Vikram, to your question regarding, what my focus is. So currently, I've been working in a clinical department of surgery, and the focus has always been oncology. And my interest has always been mental health. So this is how I try to link. But of course, the ultimate goal is to work and to do population-based studies, because that is the actual population we want to I want to work in. So ultimate goal is not to just to cater to a specific group of patients. It's ultimately to cater to a larger population. So we'll discuss it further. So I think dementia is one thing that was that we discussed, and I think it looks very interesting because this population is the most neglected, especially in our part of the world where people say, oh, they're aging, so it's just age related. They're not bothered about their cognition. So I think that is one thing that needs to be focused, and I think maybe we'll take that further. Thank you.